Welcome to Health Matters, a show about what matters to your health for all in Central Massachusetts. My name is Jay Broadhurst. I'll be your host this evening. I'm a family doctor here in Worcester, and I'm a member of the Worcester District Medical Society. That is the organization in collaboration with WCCA TV, the People's Channel. That's number 194 on your cable dial, who brings you this show. I'm going to introduce my guest in just a moment, but I'd like you to think about your knees and about whether or not your knees hurt sometimes. For folks who work in jobs where they're on their feet all the time, so teachers and nurses and people in the construction industry, letter carriers, folks, they've got a lot of wear and tear on their knees. And sadly, we are bipedal folks. We stand up and walk, so we've got weight that gives us wear and tear on our hips, on our knees, on our ankles, and our feet. Knees tend to wear out. And generally speaking, I bet you're going to say, well, you might see your primary care provider about knee pain and what you can do about that. Maybe you wind up seeing an orthopedist, and you've no doubt heard about joint replacements and how you can have your brand new knee put in. Well, I am joined this evening by Dr. Edward Arous, who is a graduate, I'm pleased to say, of UMass Medical School back in 2011.
Yes.
But then went on to do his vascular surgery residency work and completed that in 2016. So you've now been in practice almost 10 years.
Just about, yes.
No, you're getting old, it seems like.
The gray hair is there.
There you go, a little bit. So what is a vascular surgeon doing on a show that has to do with this wear and tear problem that people have with their knees and perhaps other joints?
So that's a great question. If you asked me 5 years ago, would I be treating knee osteoarthritis, I would say absolutely not. But this is a new frontier in terms of the term of musculoskeletal embolization, which is these therapies to treat chronic osteoarthritis pain. It's a procedure that's done in very much the same mechanism how I treat my other patients, and that's how I sort of learned how to do this. And it's only been honestly performed in the US probably for the last 4 years or so, and I started doing this about 2 years ago.
Well, could you remind our listeners, our viewers, a little bit about the sort of the main stuff that a vascular surgeon,
Sure.
What are the things that you typically see and that you traditionally have seen?
So a vascular surgeon is essentially a blood vessel surgeon.
Okay.
So I tend to treat patients that have cholesterol buildup within the arteries.
Okay.
Similar to someone who has, maybe heart disease and they're at risk for having a heart attack. That's due to cholesterol buildup in the heart blood vessels.
Right.
Those
And you might see an interventional cardiologist who
Correct.
would put a stent in, or
Absolutely.
maybe a cardiothoracic surgeon who does one of those bypass.
Correct.
Right. But you don't do those.
So think of all blood vessels outside of the heart and
Okay.
outside of the brain. So,
Okay. All right.
And so if you have a blockage in the blood vessel in your thigh, for example,
Mm-hmm.
you might come and see me because your calf muscle hurts when you walk.
Okay.
And then I would see you and potentially do a procedure to put a stent into that artery,
Okay.
or do surgery
Right.
to reconstruct or reroute the blood flow to your leg.
And that's an artery that's bringing blood down to the leg.
Correct.
What about the veins where the blood's coming back? Do you fool around with those too?
That's probably the majority of what we do now. So the
Okay.
percentage of patients that have vein disease, the prevalence is about 25% of the population has some component of vein disease. So the way I described it is arteries send the blood away from your heart and veins bring the blood back up. What's different is that your veins don't have a heart, they don't have a pump. So you rely on your calf muscles to pump the blood upwards as you walk. You use your calf muscles in addition to valves that open and close within your legs. So if those valves, one-way valves hopefully, become dysfunctional, then you might present with chronic leg swelling, aching, varicose veins, those large bulging veins on your leg. And we treat that on a daily basis.
So the people who do yoga and put their legs up in the air, their blood comes right down out of their veins, no
On
problem.
their own,
Huh?
yep.
Okay. So if you stand on your head all the time,
You're fine.
You'd be fine.
Yes.
Of course, you'd wind up having a.
Frank's fine.
So we won't go there. So, how is it that this expertise that you have in blood vessels gets translated into something that most of us think about as being a bone problem?
Right. So when I describe how a patient comes to see me with the term osteoarthritis. So osteoarthritis tends to refer to a destruction of the cartilage or wear and tear of the knee joint.
Right.
So if we have a picture of a standard patient with osteoarthritis, so and typically that would be picture 1. So that typically
There
shows
it
a
is.
patient.
It's up on the screen. I can see it.
Okay.
We don't see it here, but I can see it.
So the picture shows that thankfully we have good red arrows.
Yeah.
So on the normal joint space where there's a nice gray area in between the thigh bone and the lower leg bone, that's your cartilage. You have a decent amount of padding, think of it.
Yeah, you can see there's a kind of a black line that's nice and even and kind of starts and then curves up and then curves down.
So
That's what you like.
That's what we like.
Okay.
So that's a well-cushioned knee. Over time, if you have osteoarthritis, that cartilage is essentially lost. And you might ultimately end up to really significant osteoarthritis where the bones, people talk about bone-on-bone osteoarthritis.
So this is the picture on the right-hand side
Correct.
here?
So this patient, so where it says loss of joint space, those arrows on the side are really sort of pointing how they've lost that gray-black delineation between the thigh bone
So
and the leg bone.
that gray-black is the cushion, and it's gone.
Absolutely.
Wow.
So that's typically what occurs. So this is classically treated by a family medicine physician, a sports medicine physician, and potentially ultimately by rheumatology even, and orthopedist.
Right, good point.
And there's a lot of conservative measures for management of osteoarthritis. And so there's expertise, patients who are encouraged to exercise, walk,
Physical therapy.
diet, weight
Right.
loss.
Right.
And of course, many patients, by the time they've come to see me, they've been receiving corticosteroid injections. Maybe they go every 3 months and they have a knee injection done by
Right.
their provider.
Absolutely.
And then there's even more advanced where they have what's called, people refer to it as a gel shot. It's hyaluronic acid, where they
Right.
inject sort of a lubricant into the knee, which again has sort of some evidence
Not
for it.
quite WD-40, but it's a similar
It's similar.
kind of thing of
Right.
that lubricating fluid into
Into
that
the knee joint.
Yep.
And many of those patients are either trying to delay having sort of a definitive repair of a total knee replacement, or a total knee arthroplasty is the fancy term for it.
Yep.
Or patients just don't want to have that. And that could be certainly their choice. Maybe they have had relatives, someone they know that didn't have a great outcome for it, or they just choose not to have a total knee replacement.
Well, anytime you have surgery, and it
Yes.
would apply obviously to vascular surgery
course.
too, there are, those risks of bleeding or infection or whatnot.
Absolutely.
So, but you always have that discussion with your surgeon before you have a procedure, and you learn about those risks and your benefits of doing it. But I agree with you. When I am talking as a primary care doctor to a patient who's thinking about a knee replacement, that usually is a pretty scary thing
Ordeal.
for them.
Correct.
Meaning how long will that replacement last? And will that one wear out? And what are the problems that can occur? So here we have a patient. We've seen the picture of that bone on bone. The cushion is pretty much gone. The knee injections have not, maybe they've helped for a while, a few months, but then, the pain comes back. There have been medications that they've tried. They've tried rubbing things on.
They've been taking
skin.
like topical creams, topical
Exactly.
anti-inflammatories or oral anti-inflammatories, which again, long-term, patients may not want to be on those medications. They might not want to have steroid injections to the knee every 3 months for 2 years.
How does it that we've been talking about cushions and bones and mechanical kind of stuff, but you're a vascular surgeon. So what happens to the blood vessels?
So ultimately what's been discovered is that a lot of the issues with the degeneration of osteoarthritis. So I tend to describe to my patients that osteoarthritis is a degenerative disease,
Right.
certainly, but it is also an inflammatory disease.
Okay.
Inflammatory implying that you also tend to sprout new blood vessels heading towards the area of the knee. So we have a picture for that as well.
That's
So
right. It's picture number 2, I
so,
think.
so that's a term called angiogenesis, which
Yeah.
is a common term also used in cancer treatments or
And that's come up just now.
yes. So if you use the picture at the top, that's sort of the standard, we use the term vascular tree. That's the way the blood vessels would typically run, say from left to right on your screen. And then over time, if your body or cells release signals to sprout new blood vessels, you will then essentially sprout new buds, as if like branches developing from the tree. And this could be done from a totally different topic, but cancer cells release hormones to induce new blood vessel formation so that these cancer cells can grow. At the same time, as you form angiogenesis and towards your knee joint, you can form things called bone spurs, osteophytes, which are sort of potentially more uncomfortable.
Extra bone where it's not supposed to be.
Correct.
Got it.
And in concert with the formation of new blood vessels, there's also something called neoinnervation, essentially the formation of new nerve endings. So the nerve endings are in essence what causes the pain that you develop when you potentially are walking on an osteoarthritic knee.
So, I mean, if I'm in my garden, I'm thinking about, more growth is good. But in this inflammatory environment, more growth of these extra branches is a sign of problems.
Potentially, yes. So that's what we've discovered. So the topic of genicular artery embolization, which is essentially the procedure that we're discussing today. So it's a bit of a misnomer. So genicular arteries are referred to the arteries that branch off the blood vessels around the knee. There's anywhere from 6 to 8 of them. And then embolization refers to any procedure where you are intentionally shutting off the blood flow to that artery. So for example, a common, hopefully it's less frequent, but if a patient came in as a car accident and they had an injury to their spleen, in an emergency, we would embolize the spleen. So we'd intentionally shut off the blood flow to the spleen so that the bleeding could stop and the patient can resuscitate, etc. In severe scenarios, sure, you have surgery to remove the spleen as needed, but a lot more has been pushed sort of in this non-invasive methodology. So as a vascular surgeon, where I am doing procedures where I typically open up the blood vessels.
Exactly. I was just thinking you're putting stents in to try to get blood down to the calf, right. Or the heart doctors are getting the blood to the muscle of the heart.
I'm in essence traveling through the same vascular beds I've done for 10 plus years, but with a different intention. So every day when I do these procedures, I drive right by the genicular arteries and I don't pay 2 seconds paying attention to them, except if it's a patient with significant knee osteoarthritis. So what I do in that scenario is I stop and I will then inject my catheter with sort of a little wire, or a little, catheter's little tube, a little hole at the end, and I inject there's different type of products into these genicular arteries to shut off the blood flow going to that area of the knee. So that's the process of embolization.
Okay. But you can't shut off all of the blood flow to the knee.
Absolutely not.
So how do you decide how many of these embolization things you're going to do?
So most patients have 6 to 8 genicular arteries coming off the thigh blood vessel. If you are a patient that's not had a knee replacement, we typically try to treat somewhere between 2 and 4 of them. If you had knee replacement, because this has also been done in patients post-total knee replacement,
wow.
And we tend to treat 1 to 3, a little bit less. The anatomy is a little bit different for that scenario, but I would say the majority of patients we see are what we say is patients who have never had surgery within the knee joint before.
Wow.
But it's really meant for what I'd say is 2 types of patients. Patients who are either not candidates for a total knee replacement for one reason or another, heart conditions, whichever, or patients seeking to delay knee replacement.
All right. Let's get back to that in just a minute. I'd like to turn to our audience again and say this is Health Matters, a show about what matters to your health here in Central Massachusetts. My name is James Broadhurst. I'm the host tonight, and I'm joined by Dr. Edward Arous, who is a vascular surgeon here in Worcester, trained in Worcester, and he's teaching us about a new approach to dealing with the wear and tear problems that occur in your knee called osteoarthritis.
Correct.
So I'm interested because I've not ever had this done to me, nor have I gone to see it. But how do you just said, like it's obvious and easy, you take this catheter and you put it in the genicular artery. Well,
How is that actually?
I was going to say, where do you stick a needle in my skin in order to, are you poking around my knee, or are you poking around somewhere else, or what?
So I will either poke around, so I'll either numb up the skin and put a needle into the artery in the groin, in the femoral artery,
Okay.
or I would go through the blood vessel in your ankle, in the artery in your ankle.
So we either go
So
from above down
from
or
above
below
down,
up.
correct.
I see.
And so
Okay.
some of your arteries, these genicular arteries, these 6 arteries, some of them are down going, they follow the path of your leg, and some are up going. So most of the time, I won't know which one until we're in there, but usually we're able to get into most of them from either direction.
And you can have an X-ray going, and you can put something through that catheter that shows up these vessels
Absolutely.
on the X-rays, so
So-
that you know exactly which vessel you're. And can you see ones that have more of those bad branches than
Correct.
others?
Yes, so this is done, I do this procedure in the office, so patients
Oh, in the
are-
office?
I do this in the office, so patients are...
Well, you don't have to go to the hospital for this?
No, so I do
You're
this...
kidding me.
Yeah. So I do this in the office. You're
Wow.
you're in a Johnny, etc. We
Yeah.
would laying on an X-ray table,
Okay.
and then you have a nurse. There's myself. There's usually a radiation technologist, and an assistant. And then I would put the needle into whether the groin or the foot as necessary, and then I will inject dye into your leg to show me basically the path or the road map of the blood vessels going to
Right.
the knee. Then I have to use a special type of catheter to get into
So you
each of these
follow the
arteries.
road map.
And then I will take another picture. So we have picture 3, which was a good representation.
Oh, wonderful.
So that,
Yep, that's up on the screen
So-
now, and
Correct.
there on the left looks like one
So-
of those
yeah, so there's
branches there.
So on picture A, so you probably can't, it's a little hard to see, but there's actually a catheter coming from the top part of the screen heading down into one of these arteries going into the knee joint.
I see.
And then all this gray area tends to be pretty well localized on the bottom right of the picture.
Mhm.
That is the angiogenesis. That is the hyperinflammation. We talk about a blush.
Okay.
So this gray blush. And so we inject these. So historically, I say we've been using 100 micron beads. So 100 microns are exponentially small.
Right.
And they will disperse amongst the beds or the
Mhm.
tree buds of this artery. And then we sort of calculate how much of that to inject. And then we take another picture, which is now B. So in B, I've been able to eliminate all the blush on the bottom right, but the main artery is
Yeah.
still open. So
Right.
that's when I say genicular artery embolization is a bit of a misnomer, because I'm not actually embolizing the genicular artery. I'm pruning the branches or the capillaries that come off of that artery.
I see.
And so fundamentally, I am not doing anything to change the pathology of your knee.
Right.
You still have osteoarthritis. That I am meant to blunt the pain sensors, the nerve generation at this area, but over time, you will form more angiogenesis and form new branches.
I see.
And that's the issue. So that's what we're trying to deal with.
I see.
So there are studies that are being done prospectively to evaluate. There's a 4-year study, which is in year 3 right now. It's out of the UK.
Mhm.
It's the Genesis trial. And so that has shown pain reduction in patients up to 3 years after this procedure.
Isn't it? Now, so I can't help but say this. You're kind of an arborist.
Essentially. Yeah.
Well, so you're trimming off. That's really pretty cool, because you're still preserving the blood flow that's necessary, but just getting rid of all of those tiny little branches that are involved in and the proof of the pudding is that when this was first studied, people's pain decreased.
Correct.
I
That is
mean,
so.
how much are we talking? Are we talking from it's horrible to, it's manageable, or it's horrible to you really feel like dancing?
So it depends on the patient. And so in all comers, the patient, about 70%, it's 65 to 70% of patients notice a significant pain reduction.
Yep.
And what these trials and what we're, because we are tracking our patients prospectively, if you came in to see me, you'd be filling out a couple pain scores, and then I'm similar getting these scores done after the procedure as well. Because I'm trying to identify who is the best candidates for this kind of procedure. Typically, the patients with more advanced osteoarthritis, bone on bone, those tend to be the hardest to get a good response with. Okay. I think fundamentally, it makes sense. They fundamentally have the greatest cytokine response for the inflammatory area to that. Right. But patients that are in the moderate range tend to have a great result. And so when I've met with orthopedists about this procedure where, they've sent patients, I was expecting a lot of patients that were too old to have surgery done. And surprisingly,
but it could be people in their 80s or 90s, that kind of patient.
Maybe not a great candidate for general anesthesia surgery, could not tolerate the rehab.
Well, you're doing this in your office.
Correct. So I'm going to say I'm seeing a lot of 40 and 50-year-old patients that I still see 60, 70, 80, but patients that the orthopedist is looking to delay surgery on. Maybe someone who's played hockey their whole life and has a lot of wear and tear on the knee, and there is a lifespan to a total knee replacement.
Right, so exactly. That's one of the things. The replacement parts are never as good, whether it's teeth or knees or whatever. What you're born with, generally speaking, you'd like to stick with.
Right. So if I can get them several years of relief, and I could do this procedure again down the road to get them to a point where they can handle a total knee replacement as necessary. If you're already scheduled for a total knee replacement, you've been deemed to be a good candidate for it, have the total knee arthroplasty, the total knee replacement. But if this is something you're looking to delay or you're not a candidate, not interested, then this could be a good option for you. And it's done totally percutaneously in the office. So it takes about an hour. Patients go home about an hour later.
So the patient doesn't need to have, anesthesia or conscious sedation or things like that. They're just lying there and you're talking to them.
Yep.
Is that right?
So sometimes patients will fall asleep. They get a little Valium. They get some oral sedation.
You get some medication and that just kind of relax you.
Correct. So you have some IV. You have an IV if necessary, but the rate of us actually needing to provide IV medication is relatively low. You need a driver, someone to drive you in and be with you that evening, someone to stay with you that night. Right. But no, the procedure time, somewhere between an hour to 90 minutes, and then you recover between 30 and 60 minutes, and then you're home. We tell you to take it easy for a couple of days, but that's it.
And so that's just it. Take it easy for a couple of days. It's not like you're out of action for 2 weeks or something like that.
No heavy lifting, no strenuous exercise for 72 hours.
And then you see the patient back.
Yep. So we usually see the patient back in a couple weeks. I will say, typically patients' pain is a little bit worse for the first couple days after. That's actually common with most embolization procedures. But then you start to see improvement about a week after.
And is that pain that for a day or two after, is that the same pain that they've been experiencing, or is it somehow different, maybe related to the procedure or something? It
might be more related to the procedure. So, going back at the tree bud analogy, when I inject these beads down, my job is to make sure I'm in the right artery. But those I can't really control which branches those beads are going to go down. So in essence, some will go, it's common, some will go to the skin there. So common for patients to notice like purple splotching of the skin, which is transient. That lasts a few days and goes away. But I do think that contributes to some of the discomfort. What I have switched to is, and I use I mentioned these 100 micron beads. Right. We actually now use a reversible agent so that they resolve within a couple of hours. It still produces the effect by shutting down the capillaries, but the obstruction within the superficial vessels is believed to be less. I also do things where I put an ice pack on your knee during the procedure because I'd want to constrict the blood vessels at the knee, at the skin level, to direct the beads deep down to where it's warmer, which are dilated.
Isn't that clever?
So and then when the procedure's done, I wrap your leg up in a heated blanket to reperfuse or restore the blood flow to the skin blood vessels.
That is brilliant.
So there's things that we have learned.
It makes fantastic sense, but I don't know if the people who did the original studies were smart enough to think about putting an ice pack on during the procedure and then warmth later on.
The embolization, so I mentioned the musculoskeletal embolization sort of frontier is what's coming with us. So it's a change of
So
topic.
we're running a little low on time, but I'm eager for you to just share. This is something that is currently available for the knee. What about other joints or other problems that people have? Could this have a role for those?
Yes, so that's what's being investigated now.
Okay.
I say we have a good deal of evidence for knee osteoarthritis, and that's why we began doing it. The
Right.
current studies that are being done are more so for frozen shoulder, plantar fasciitis.
Okay, so
Sort of-
frozen shoulder, that's you just can't move, and if you move, it hurts like the dickens.
Correct.
And plantar fasciitis, I imagine a number of our
There's a lot of it.
listeners have experienced that, where they're told to just roll tennis balls or frozen bottles of water, and it helps maybe a little, but not much.
So those are, I'd say, the next two. Hip osteoarthritis, the anatomy is a little bit different, but that is being investigated as well. But that's where I foresee things developing in the next several years.
So the mechanism is the same,
It's the
where you
same.
get this angiogenesis, and what you're doing is you're taking that down. You're pruning those. You're shutting off, and people.
That's right. That's how we do it.
The way things are better is because people feel better and they can do more.
That's
Boy,
right.
that's remarkable. I wonder if you have any last thoughts, things that we haven't talked about so far that we should, or things that I haven't asked you.
So one thing that most patients ask me, who is not a candidate?
Good point.
So
Thank you.
So I told you at the beginning, I'm a vascular surgeon. I deal with patients who have blockages in the blood vessels.
Right.
If you see me in consultation, my job at the initial visit is to make sure that you do not have any blockages in the blood vessels in your legs.
I see.
Because if you do,
Yeah.
you might be more dependent upon these genicular arteries as sort of collateral blood
right.
vessels.
Okay.
And so I would not want to shut those down. So that's up to me to assess at the initial visit. But those are commonly seen patients who have chronic calf pain,
Got it.
smoking, etc.
Well, what a wonderful show, and thank you so much for enlightening our listeners to this brand new and really exciting addition to the toolbox for things that we as the medical community can offer folks with that wear and tear arthritis of their knees. My name is Jay Broadhurst. I want to thank you for joining us here on Health Matters. My guest today was Dr. Edward Arous. He's a vascular surgeon here in Worcester. This show is made possible by our wonderful engineer, Frank Rocco, who I thank, and I hope you'll join us next time on Health Matters.